morning. I think we're going to get started. There are some more seats up here in the front if you need a chair. Welcome. My name is Chris Trieber. I'm the chair of the LEICC. And welcome to the IAC, which is the Office of Transparency. So before we get started, I just want to review the procedures for the LEICC meetings. Attendees should pre-register on the New York City Department of Health and Mental Hygiene Bureau of Early Intervention website for the meetings. The meetings are open to the public, but the audience does not address the LEICC members during the meeting. Audience members may sign up with Felicia, who is right there, if you want to speak during the public comment section. And then as of May 15, 2014, the New York City Local Law number 103 of 2013 and the New York State Open Meeting Law require that open meetings be both webcast and archived, and this meeting is being recorded today. Transcription is available for the meeting, and written minutes for the meeting will be available. Good morning. I first would like to introduce to everyone a new member of the LEICC. I'm very happy that we have a new parent member, Cindy Chow. And I'll just give you a little bit of information about Cindy. Cindy is a teacher and an advocate and a mother of two. Her 4-year-old daughter received early intervention services since birth. Cindy holds a master's in elementary education from Teachers College and a master's in marriage and family counseling. She's a mentor for families with children with multiple disabilities and is currently working on a project helping international orphans with special needs. Cindy is excited about being a member of the council and advocating for families receiving early intervention services, and we're really happy to have new parent members of the council. So before we get started, I think I'd just like to go around so Cindy has an idea of who everybody is, so maybe we'll start with her.
Marie Castellino, Assistant Commissioner, Bureau of Early Intervention.
That's me. George Askew, the new Deputy Commissioner for the Division of Family and Child Health at the Department of Health and Mental Hygiene.
Emilia Rakiti, Bureau of Child Care, the Health Department.
Tony Rodriguez, parent.
And Nancy Calderon, provider third here.
Lauren Castro, Nancy, Department of Education.
Tracy LeBright, Public Health Solutions.
Mary Fay, Higher Education, Brooklyn College.
Roselle Maisto, provider Little Wonders.
Linda Silva, Village Child Development.
Kathy Ortega, Early Childhood Direction Center. Rina Splencia, the Alba.
Good morning. So I first would like to introduce Dr. Askew, who is the Deputy Commissioner for the new Division of Family and Child Health, and we're really happy that you're able to join us today. So Dr. Askew is a pediatrician who has spent the vast majority of his professional career dedicated to addressing the health and well-being of young children and their families through direct service advocacy and policy change. He joined the department in November from the U.S. Department of Health and Human Services, where he was the first Chief Medical Officer for the Administration for Children and Families. In that role, he helped develop and administer initiatives and policies aimed at addressing the health needs of children, particularly young children, and families facing significant economic and social challenges. Dr. Askew previously served as the Deputy CEO and Chief Development Officer for Voices for America and as CEO and President of Jumpstart for Young Children. Additionally, he is the founder of Docs for Tots, a pediatrician-led child advocacy organization that helps doctors advocate beyond their clinical practices on behalf of the youngest children. The Division of Family and Child Health that Dr. Askew oversees was created by Commissioner Bassett and includes the Bureau of Maternal, Infant, and Reproductive Health, the Office of School Health, and most recently the Bureau of Early Intervention. Welcome.
I guess I should say something, right? I like to stand so I can see everybody, first of all, and also as a pediatrician, I have a fairly soft voice, which is great as a pediatrician, but sometimes not so great for public speaking, especially without a microphone. So thank you for allowing me to be here today. I'm actually very excited. Raise your hands if you walked into that construction as you were coming in here today. There we go. So I'm not the only dummy. I'm sorry. How many people were delayed this morning? A lot of people delayed on the subway. I was delayed, but we all made it. I'm also very happy to see a smattering of men in the room. It being in this field for a very long time, you don't see many gents who are doing this kind of work, and I really appreciate men who enter a field where we nurture and raise and support young children. So we're not seen very often, but I know that the ones that are there are very committed to this work. So thank you, gents, for your efforts. When I met Mary Bassett, Dr. Bassett, back in June of last year over coffee, it was because I had been recommended by First Deputy Barbeau, who's an old colleague, as a senior person who could lead an early childhood effort in forming this new division. I guess by senior, I guess means older, so I must be getting up there in my career. When she told me about this new division, sort of bringing together all the child and family-facing efforts in the department and trying to put them all under one umbrella, I was excited. So she said, well, there'll be the Office of School Health, which gave me a smile, and there'll be the Bureau of Maternal and Infant and Reproductive Health, which gave me a smile. And then she said, and we're trying to move early intervention into this new division, and that really gave me a really big smile. And that really was kind of a make or break, to be honest with you, around the job. Because if we were going to, if we're really going to attack early childhood, this is where you want to start. I certainly value the Bureau of Maternal and Infant and Reproductive Health and the Office of School Health. But then there's a gap. There's that 0 to 3 gap, and we were able to sort of fill that 0 to 3 gap. We still have a gap, that 3 to 4 or 5 gap before we get to UPK, but we're going to work on that too. So I was really excited when this actually came to fruition, and really is a big part of why I'm here. So the work that you're doing and the efforts that you're making are really a significant part of why I chose to take this job. I left Washington D.C. and left my family back there to come here and be with you all. They don't mind though; they get to see me on the weekends. But when I came, I didn't want to set my own vision here. I didn't want to come here and say, I think this is how it should be done. I really thought that we should have a shared vision within the division, something that we all could participate in, and really did some visioning work with the team and took them off-site with the facilitator. And we came away with sort of with a vision that every child, woman, and family in the city of New York be empowered to reach their full health and development potential. And I think that really speaks very directly to the work that you do here, especially with regard to the word empowered. That's what we're trying to do with families. That's what we're trying to do with kids, and we really want the kids that we serve to reach their full health and development potential. And that is something that's a theme that flows through the entire division. So know that that's there. And then we wanted to focus on a couple of priorities, and one of those priorities that emerged was early childhood. We really want to focus on something. One of the things we want to look at is early screening, and we're going to be pushing for universal screening of kids. And so we're really going to be banging on the child care providers' doors and offices and saying, we really have to do this. This is a part of your job, and you know it is, and you want to do it. And we're going to see if we can make sure you get paid to do it too. A lot of complications in that. And also preventing unintended pregnancy, which is another one of our big efforts. But I just wanted to just sort of know what the division kind of looks like, what we're thinking as we're moving forward, how you fit in into the work that we're trying to do, and how important we think it is what you're doing. And that my door is open. I'm still in the learning mode. I've only been here for 4.5 months, believe it or not. Gosh, it seems like it's much longer because I'm having so much fun. I haven't had this much fun in a long time. So feel free to call me, send me messages, text me. I'm on Twitter. Stop in and see me. I love meeting folks and learning what you're doing. And so my door is open, and I'm sorry to say that I'm going to have to leave here about 11, but I'm going to get hopefully a good feel for what goes on here, and certainly we'll be back. So thank you.
So, thank you all. Special thanks to IAC and to Chris for hosting us today. Our usual meeting room in Gotham has been taken over for other purposes for the department. So we were displaced temporarily and taken in. So thank you. I'm going to start off with our department report about talking about the local determination, which is really an annual performance report for the city and the city's early intervention program, and for the work that everyone in this room is doing. So each year we submit performance data to the State Department of Health. The State Department of Health in turn submits that performance data to the federal government. Over the past few years, the State Department of Health's assessment of our work showed that we needed to make some improvements. So what did we do? We updated our policies and procedures. We changed some of the aspects of the Bureau's work, starting in the regional offices and all the way up to how data was managed, how we analyze data, and how we work together within the provider community, including our enhanced provider oversight process and our working with the provider community to improve performance. I'm pleased to report that all of that hard work and those years of efforts have paid off. Dedication to the program has shown the results, and this year's local determination for New York City shows that our compliance meets requirements, which is the highest possible ranking you can get. So thank you to all. I'm going to go through some of the information that put us in that category. While we still have some work to do on our 45-day compliance, as I present some of the numbers to you, you'll hear that. We also continue to exceed state targets for important indicators such as percent of children served in New York City. So, indicators. The state target for the start date of services, we all know that is the 30-day. It is 100%, so the compliance, the target is 100%, but the federal indicator says that we should be achieving 100%. In New York City, federal fiscal year 11 to 12, our performance was 69%. Federal fiscal year 12-13, 88.7%. The statewide performance was 88.5%. So just a touch over the statewide performance. State target 45-day compliance, again, one of the federal indicators. 100% is the target in federal fiscal year 11-12. New York City compliance was at 72%. We increased in the next fiscal year to 75.6%. Statewide performance 82.5%. So we still have some work to do on our 45-day, but we're definitely going in the right direction. State target for percent of children served birth to 1 year of age, 1.22%. New York City federal fiscal year 11 to 12, we were at 1.11%. The next year, 1.25% with a statewide average of 1.22. Again, slightly exceeding the statewide average. State target for percent of children served birth to 3, 4.09%. Federal fiscal year 11-12 New York City, 4.12. The next year we were at 4.57%, with the state average being 4.04. So it's important to remember that the work of the Bureau is a collaboration between the Bureau, provider community. It has to do with how data is collected, how data is analyzed, but it comes down to the fact that everyone is working very hard within this program to be sure that the children and the families are getting the service that they have been authorized for and that they should be getting in our program. It is about delivering the services to the children and families. So thank you to everyone who participated in this, beginning in the Bureau, but certainly going out into the provider community. The next part of my report is on the SEICC, the State Early Intervention Coordinating Council. Since our last meeting, there have been 2 meetings. So I'm going to report on 2 meetings, the December meeting and the March meeting. I'm going to start off with the December meeting talking about the Task Force on Social and Emotional Development, and we presented some data to the task force, which was subsequently presented to the SEICC. We're going to present that data to you here, but I'm going to leave it till the end of the discussion of the March meeting, because just to give the committee some opportunity to have a good discussion about the data that was presented statewide from New York City. So the Task Force on Social Emotional Development we've talked about before was created about 1.5 years or so ago by the SEICC. There are SEICC and non-SEICC members on this task force, and the focus of the task force is to create a guidance document for the field to address and highlight critical relationship between children and their parents, caregivers, promote family-driven approach to services, promote the concept of trauma-informed care. By the December SEICC meeting, there had already been some draft documents presented to the committee. At the December meeting, the state informed us that they had identified some funds to be able to bring on a consultant editor to take the work of the various work groups, to put it together into one voice and make it a cohesive document, because there are a number of work groups. And this was the meeting this was the SEICC meeting that the task force brought the New York City data for discussion. And as I said, I'm gonna delay it to the end of the SEICC report, so that you can see the data. We are gonna project the data on the screen and allow you some opportunity to discuss the New York City experience. Also at the December meeting, there was a report by the state on the annual performance report that is to be submitted to the federal government. This was the 2013-14 preliminary data. There was extensive discussion on timely services, children receiving services in the natural environment, some child outcome data, percent of children in New York State participating in EIP, timely IFSP, or what we know as the 45-day. Full discussion by the committee, and there was a vote by the SEICC to submit the information to the federal government. Nice update, considerable discussion. The overarching theme in any of the nice discussions presented by the state is that they continue to work on enhancements on reports and functionality. There was also a presentation on the state fiscal agent and post-April 2013 transition, looking at data at the time of transition and the subsequent years. What the state presented was that enrollment in the program essentially unchanged, 2012, 13, 14. Rendering provider capacity has increased 5.8%. Ratio of providers to children remains constant at approximately 4 therapists per child. This is statewide data. The number of billing providers has declined 20.4%, but the presentation proposed that this was probably due to rendering providers consolidating into fewer agencies. Payment cycles have improved. Mean time for full payment to provider agencies equals 15 days. Mean time for payments to independent providers, 20 days, as of the SEICC in December. The number of days from date of service, the number of days from the date of service to the date the claim was submitted to the EIP by the provider community, mean time 54 days in 2012, decreased to 39 days in 2014. Commercial insurance. Claims submitted and adjudicated by commercial insurance within 60 days, 91.6%. 15% of submitted claims were reimbursed by third quarter of 2014. I'm gonna go back to the issue of commercial insurers because it did provoke some discussion at the table. The state also talked about the AT process that had been implemented in October 2014 in New York City and was going to be incrementally rolled out to the rest of the state. There was discussion about the percent of payments received from the insurers. Brad Hutton stepped in at that point in time to clarify that there are two percentages that the state is looking at regarding the statewide fiscal agent and commercial insurance billing claiming. 2% is the percent of all dollars spent on EI in New York State that is supported by dollars from commercial insurers. 2%. 15% is the percent of claims submitted to commercials that are paid. Two different percentages that the state is monitoring. There was also discussion at this particular meeting regarding the administrative burden to providers for billing post-April 2013 and consideration of a rate increase to cover that burden. I'm going to switch now to the March meeting, March 12th, 2015 meeting. Very short beginning to the meeting because the majority of time spent at this meeting was spent on a discussion and decisions regarding the SSIP, which is the State Systemic Improvement Plan. State informed us at the beginning of the meeting that the update to regulations that we worked on about a year or so ago, I think some of the people around the table may have presented some or been involved or looked at some of the proposed regulations. And remember, these are regulations that have to be modified at the state level to come into compliance with recent changes to federal regs. So the state informed us that they were far along in the process. They still need to have public hearings. They should take place late spring, early summer. And the next package, there were two packages of regulations that were going to be sent out to us. The first package is the one we saw that they felt were the easier fixes to the regulations. But the next package that should be coming out soon would involve more complex regulatory changes. Health homes, Lydia Ledniak is going to do a more extensive update on health homes as it applies to New York City and what that's going to mean, but I can tell you from the presentation at the March meeting, the state informed the committee applications had been received, the health home applications from the provider community had been received. The planned implementation, October 2015, EI phase in early 2016, considerable discussion around the table regarding exactly what that was going to mean to the families. A lot of questions about eligibility determination versus determination of acuity. The CANS, those of you who have been involved, the tool that is being assessed to determine level of acuity. There's still work being done on that to be sure that it's applicable to the child population. So the remainder of the March meeting was dedicated to identifying the measure for the State Systemic Improvement Plan, and this is coming from the federal government. It is a federal requirement for each state to identify a comprehensive, ambitious, achievable plan designed to improve results for infants, toddlers, and their families. These have to be measurable indicators. They have to be measured, measurable. There has to be an infrastructure in place. There has to be experience with this. There has to be involvement of stakeholders. It is a significant plan for improvement focused on outcomes that will take place in the state over a number of years. The state actions to date were data analysis, extensive data analysis, infrastructure assessment, identifying measurable results, again, important outcome, not process measure, and identifying the improvement strategies. So, to that end, the state presented to the SEICC a multi-year experience with outcome surveys and work. The state for approximately 10 years has been doing a child outcome study, and many of you have been involved in this. These are the child outcome surveys that are completed by the IFSP team at entry and at exit. I see lots of nodding heads. Yes, you have been doing this work. The items that are assessed, child functioning compared to other children, her age, and really improvement of those skills from the point of entry to the time the child is transitioning out of the program. So, child outcome survey, identifying child outcomes as our SIP was one of the considerations. The second consideration was family outcomes. And the state, over the course of these number of years, almost 10 years of work, has developed with consultants a family survey that has been either mailed to the parent hard copy or they've invited the family to complete the survey online. 3 key elements to family outcomes. 1 is helping the family know their rights. 2, effectively communicating their children's needs and helping their children develop and learn. So, presented to the SEICC, focusing the SIP for the next number of years on child outcomes or family outcomes. The measurement scales had all been identified for both. So 2 paths that the SIP and could have gone down and the SEICC would be supporting. The state at the meeting was promoting family outcomes. I can tell you it was well received by the SEICC. The SEICC had a very rich discussion, very good discussion with the individual who had developed the scales, the surveys, presented the data, talked about the analysis that had occurred to date and the potential for the analysis. And after much discussion, the SEICC voted to focus its SSIP on family outcomes for New York State, using the tools that have been created to date. The basis for this decision is, as we know it, surely as we know it in New York City, is there is a strong relationship between increasing or improving family outcomes, their knowledge, their self-efficacy, their access to supports. We know that family support, family knowledge, family empowerment will work to the benefit of the children. So the SEICC supported this. New York City has been working on this. Clearly, New York City supported it at the table. And the focus going forward for these next few years will be on global family outcomes. I gave you the 3 examples, but the other items that are included in the survey are parents expressing their feel that my efforts are helping my child feel more confident in my skills as a parent, find resources in the community to meet my child's needs, use services to address my child's health needs, advocate for my child. It is a very long list. I picked out some of them, what I believe are the most salient elements to the survey. We are obviously entirely supportive of this plan and confident that the work we've been doing in the Bureau and with our provider community is gonna put us in good stead and certainly shine some very positive light on the work we've been doing. So, there will be more to come, I'm certain, on the SIP.
But I just have a question,
Sure.
not so much in the determination of focusing on family outcome, but my question is, did they mention, they have how many years of data on child outcome? Did they present that data? Are they doing anything with that data? We just fill out those forms and never know what they do with that.
Yes, they presented some of the, yes?
Okay.
They presented some of the data at the meeting with them. I'm not sure how much of the data I have either electronic, I will go back, because it was a very long, very detailed discussion, very interesting, I can assure you, very interesting. The consultant who had been working on this did a very extensive presentation, there is some data, but there is still more work to do, and that's why the SIP is important for us to continue to do this. So I will share with you what they have sent to me.
I just kind of wonder, because obviously I'm listening to you who is listening to them, but one wonders if they've had, 10, 15 years of data, as long as they've been doing outcome studies of how children have come in at entrance and leave at exit, and what do they do with that data? And then I would wonder if the focus is going to be on family and family outcome, would there ever be a measure, against the newer data of family outcome and outcomes for children against the older data that didn't focus on family, family participation? That's what I would have, that would have been like an interesting study, but I'm just, so it's kind of up in the air.
So, good question. The focus of the meeting really was on which of these outcomes are we gonna focus on. I will, as I said, we've got subsequent information. I can send to you what I can send to you, what I can share with you. I expect there will be more discussion in
And I think
subsequent
that's
meetings.
interesting, because they have a giant thing to start working on, even though they have 10 years to do it or something. Enormous thing, they have to start doing it, it's a long project.
It's a long project, but my understanding of the process is it started out focusing on one area and then developed. There was layering on of different aspects, which in a way is going to really serve us well, because we have this many years of the statewide experience to get to a family outcome survey that I think is going to serve everyone well.
I'm glad I'm not the one who has to do it, but I think. Okay, thanks.
Any other discussions, questions about SEICC? What I want to do now, we're good on the SEICC, yes?
Can I just ask one other question?
Sure.
And I'm assuming, like, the easy package versus the more complicated package. There was, I remember when Donna had done the original presentation on the whole systemic improvement, they were talking about, capitating, fixating, whatever word they're using in terms of service coordination rates. Wasn't that part of that whole improvement, that they were going to look towards legislation?
I'm trying to, you're right, there was, well, yes, there was this RAP, the Reimbursement Advisory Panel, and the one very specific recommendation that came from the RAP was to look at the payment structure for service coordination. And I'm trying to remember.
I remember when Donna originally made a presentation.
Yes, it was in the regulatory.
It was, right?
Right, yeah.
Because I remember a lot of this stuff was just conforming to the to the federal regulatory language, and it wasn't a big deal. It was
Right.
assuming is in this first package that you
Yeah.
referred to.
Yes,
But then there was something about the service
yes,
coordination.
that's right.
And changing the rate structure, and that wasn't spoken about, I guess,
Not specifically, not
so
specifically.
it's still out there. Okay.
So Marie, when you said the global family outcomes, does that mean just more variables, or are they looking longitudinally, or?
There were more variables. I just went down this very long list of the items that are included in the family survey and picked out a few that I thought would be most pertinent for our discussion. But the family survey has many more elements to it, many more questions to it.
So they're not increasing like the longevity of the study, they're looking at more variables in the global.
To my understanding, Mary, yeah.
You mentioned as part of the family's ability or their feeling about community resources would mean early intervention within the communities or other services that could complement early intervention in those communities.
From my reading of the survey, it goes beyond early intervention, and it's really, in a sense, empowering families to reach beyond early intervention for other services they would need to support their child and family, yes. And a copy of the survey was distributed at the SEICC. I don't believe I have it electronically, but I can scan it in and I can send it to the members of our LEICC for you to see. I'm not certain that that's exactly the survey that's going to be used going forward, but you can at least see the elements included in that. There are many questions, and they're all, I read through them, I'm like, this is good, this is good, this is good, this is good. So I can scan that in and send that to you. Okay, great.
I don't know if I missed it. Was there a discussion about how often that would be sent out, how that would be disseminated?
No, we didn't get to that point. So what I wanted to do is go back to the data that was presented to the Social Emotional Task Force from New York City. And the Social Emotional Task Force presented this information to the SEICC. So I'm going to ask Nora to do this presentation.
So this was really to answer the underlying, that constant need of no child is diagnosed with a social emotional delay. That was really kind of where that push was coming from. And we happen to have some old data around this issue to look. And the first thing I can tell you is that it's true, no child is diagnosed with a social emotional delay alone. I think I found 3. But when you think about children 0 to 3, that makes perfect sense that they're not, if they have a truly severe delay in social emotional, that's not the only place it's going to be manifesting. And so we looked at the data to come back to people who were saying, well, we don't see children who only have social emotional, or what kind of services, if it's not this service, it's not a true social emotional. We have a lot of children with social emotional delays. We chose to make a distinction between autism spectrum disorder and other, social emotional delays, because they are a pretty significant spectrum even beyond the autism spectrum. And as usual, we made our usual distinction between children and the age at which they come into the program, because we do find that their delay profile tends to look very differently depending on whether they're over or under 18 months of age at entry. And so what you can see though is that that first set of columns is children who come in under 18 months of age. They tend to have, physical problems usually is what we're seeing there, and often just one domain. Well, even with only under 18 months of age, 5% already have an ASD diagnosis, and then another 17% have a social emotional delay of some kind. So that 22% of children, even under the age of 18 months coming in, have a social emotional delay, basically a fifth of our kids. And when you look at the older children, the second set of columns, so over 18 months, what you see is that these days, incredibly, 19% of children with an ASD diagnosis, but another 24% with a different other kind of social emotional delay, whether it just doesn't quite meet the assessment criteria or it's a very distinct issue, which would bring you up to 43% of children in that age group with a social emotional delay. So what we were hearing as this social emotional task force was getting underway was this is such an under-recognized condition, and of course it is, but the implication at times that it's completely unrecognized, that no one acknowledges the social emotional delays of very young children, is just not true. So that even when you look at them as a whole, 13% of all our children, regardless of age, have ASD, have a diagnosis. Most of them pick it up while they're in the program, but they do get it. And then 21% have another social emotional delay. So 44% of children have some form of social emotional delay that has been identified and addressed in their IFSP plan. And as I said, this was really very specific to the concern as this group got going about what is the level of awareness, do people know about these issues, do they know how to evaluate for these issues, and do they know what services to provide to address these issues. And while there's needs in all those areas, I think that the recognition piece is not as dire as people made it out to be. If we already know as while they're in our program that this many of them, we are aware of the problems. And then the next slide I think was just a visual of the same thing. Easier to look at. Next slide. Next page. Sorry. No, he just did it. It's just the same.
Bar
the
chart.
same thing, just individual.
So the next slide was really a pie chart showing the data. Yes, yes. Thank you.
Blue, no social emotional.
It's 50%.
Dark pink, ASD, lighter pink, other kinds of social emotional. So you can just see, it jumps out a little more clearly that we're usually looking at anywhere from a fifth to a quarter of the case.
How's that? Good for something.
So we presented this data, as I said, at the task force because there had been this discussion, ongoing discussion that children are not being identified with the delay. We knew that in New York City we were recognizing this delay in our children. This data was presented really to inform the work of the task force, to guide the writers in preparing their drafts for the guidance document. They were extremely appreciative that New York City presented this data. There was a request to the State Department of Health to generate the same data statewide.
I'm wondering what, on the kids who didn't qualify for early intervention, coming with significant severe tantrums, the parent describing unusual emotional behavioral symptoms, and they don't have other delays, is a very hard population to get into early intervention and get services for. And so I'm wondering if there's some way to calculate the percentage of kids who are referred to early intervention with an emotional behavioral chief concern, and how they fare in early intervention. Because I think that captures a population that medically we seek to try to diagnose, to give some diagnosed condition with a high probability of developmental delay in an effort to get these kids service when they don't have delays other than difficulties in that delay.
From a data perspective, that would be extremely difficult, and the reason is because we actually just looked at this, more than 50% of children come in without a reason for referral. They just don't enter anything, and so we don't know what the initial concern was, and then they go ahead and they get evaluation in all 5 domains. We could potentially try to pull out results by domain, but it would actually be extremely difficult. So I think you're right that it might be there, and I don't know if that population would be more or less likely to report their reason for referral, but just that huge piece of missing data is why we've actually now looked at that question.
Let me step in and just say that the work of this task force is to create a guidance document for the field so that the field would have the basic information they need to do the quality evaluations that would identify the children to meet the eligibility standards for the early intervention program within the regulations that currently exist. The state has been very clear about the fact that there will be no change to the regulations at this point in time regarding the eligibility standards. And one of the things that has been discussed are the services that are available for children and families beyond the early intervention program. So for those children that need to be monitored, whether it's in the pediatric setting or in another setting, what guidance could be given to them. And we do have different writing groups working on the different aspects of the guidance document. The guidance document is actually moving along much more quickly than I had ever anticipated, and we should have a draft somewhere along the line. So if there is a way for us to generate some data, we could tell you that. But this guidance document is also for the field to present information regarding those children and families that would not be accessing early intervention services.
I just have 2 questions. One is in terms of the data, where had you got it specifically within the IFSP, within the evaluation? Like how did you sort of call the information?
Yeah, so within NICE, within the MDE and then reported within NICE in the MDE summary, they have to give results by domain.
Yeah.
And so we pull out, this is just eligible children. We pull out eligible children and then look to see who had a domain delay. And I would point out, it captures, the delay may have only been like a 25%, it wasn't gonna make the child eligible on its own.
It was just identified
Exactly,
as
as
one
part
of
of
the
their profile.
That's part of it.
Exactly.
And then is there any, I know at the last LEIC we talked about kids who were referred but sort of never got there and kids
Yes.
who were identified. Is there any way to look at these numbers in terms of, were there kids who once were referred and then were found later, like especially in regard to the social emotional issue?
So you think like maybe who were evaluated not eligible but came back and evaluated later?
Exactly. Or, like specifically, do you think certainly children who are in like very traumatic situations, children who might be homeless and in shelters and other things may not initially show at that young age, but certainly by 18 months, you're very, so I'm just wondering, because I know that was a discussion and things that the department was starting to look at is in that issue, it might be something to look at in terms of, are these kids being referred initially, found not eligible, and later found eligible?
Yeah.
I don't know if there's any way to look at that, but I think that would be important information.
I think we could try to look at that in the future. I think it may not stand out as much as you would expect because we were just doing some sort of hand data these days, and almost 20% of children are re-referred, and quite a lot of them get evaluated at both points. And in particular, delays like communication will show that same trend. You're not quite there now, but 6 months later you are. So it's definitely something we could look at. I just don't know if it'll jump out as much as you might expect. But it's something we can look at down the road.
I mean, in terms of continuing that, I'm just wondering out loud the relationship between a parent depression, postpartum, poverty, non-compliance, and the social emotional piece as well.
I guess I'm thinking about everything and listening to everybody, and I think think I'm probably gonna answer my own question with something you had said, but when I think about kids with social emotional issues, I mean, I know you said these are kids where it may not be the primary handicapping condition, it's probably a secondary handicapping condition. And like Lisa said, you're very concerned about the kids with the social emotional problems that might be the primary. But, and I, just as a thing, like in the 3 to 5 world, what I see a lot of are kids, I don't know if I wanna call it social emotional issues, but that's, for lack of a better term, that's what it is. It's like self-regulation. And I've been doing a lot of reading about self-regulation, and that self-regulation in a lot of the journals has now been the major predictor of success in an adult. Because if you can't get your self-regulation going, you know, you have a tough time in life. So I just don't know where it all fits in, but I think where it all fits in is more that if you identify a child who might be depressed or might have some other kind of social emotional component, a self-regulatory component that don't meet the eligibility criteria, that the guidance document is going to show you directions of where to go, but maybe not, it's not an EI kid. And I think there just needs to be a greater focus. I mean, every time you read a newspaper, it's some, you know, social emotional concerns are just not taken seriously enough in this country or anywhere else. And so you have all these horrible things that are happening worldwide. So, but it begins with the little guys. So is that the goal, is to make it clear what EI is all about, and then resources, if you identify a child who has some sort of a social emotional component, where to go and how to follow up with it?
There are portions of the document that are being generated right now. It's a very wide spectrum of participants on this document, very wide spectrum. And if I were to go down the list, you would recognize many of the names. There is a section on clinical clues. We're involved in writing the section on evaluation. We're involved, and with teams, each writing team is a team. We're involved in writing this section on the IFSP. And each person on the writing team is going to bring the appropriate information to the document. It will be a document that will provide a broad spectrum of information to the field. Again, not to say that early intervention is the only program. You still have to meet your eligibility requirements. We still authorize services, individualized for the child and family. So that theme will continue, but it will be a clarifying document for the
Sort of like the speech and language with the clinical clues and the things.
A guidance.
How do you replicate that type of a guidance document? That's what I'm envisioning.
Actually, it's more of a comment. I see a strong tie between the social emotional task force and the outcome of the guidance document with the family outcome survey. That I know you only highlighted some of those questions. I'm really interested in these other questions that are talking about the composition of the family. I mean, you know, you have to, I mean, I don't know, you know, if there's stressors, you know, different things that are not enabling them to move forward with their child, you know, stumbling blocks and any type of issues that are kind of not enabling them. So I see a nice bridge between that and helping to identify children, more concerns, and resources. Resources was one that you had talked about, more resources in mental health. I mean, that's kind of where the world is going.
Right.
So it's more of a comment.
Lord, when you looked at the data, if a child has social emotional diagnosis, what's the primary diagnosis? Communication?
Yeah, I think there was a little confusion around that. So, well, we don't see our children with only social emotional delay and nothing else. But that doesn't mean that the social emotional delay isn't really severe. It can be the primary diagnosis. It's just that it's causing ripples in other domains. I would have to go back and look because we did look at that, but I would guess that, you know, obviously communication is a common one, but I actually think it's pretty, because like with those little guys, you know, again, you're not necessarily seeing it with the communication yet because it's even almost too early for them to be doing much more communicating. It can read in the physical domain as well.
So the motoric could be.
Yeah, I mean, there's no domain that can't be affected by the social emotional. I would have to go and look at the combinations. I don't remember any single domain like jumping out as this is it. Communication seems likely. But mostly what I remember coming away with it was the idea of like, you just cannot take the child's, you know, that apart from the rest of them.
Right, it would be good to see if it changes as a child ages.
Which is
If it
usually the
starts
case.
motoric.
Exactly. Yeah, we could definitely run like the common combinations, but nothing stood out so strongly that, you know, it got on the screen.
Just want to make a comment about data. I know we need to move on. Dr. Castellino, this is another example of New York City pushing data. And all due respect if anybody's here from the state, but you know, I think that my colleagues will continue to recommend and support that the city really take the lead because I think that your department, along with the providers, provide a lot of good, credible data to the state. So I commend you for that. And I think it's helpful really to talk about eligibility. I know that the state doesn't want to change that, but I think the more data, the more power it gives to maybe reconsider looking at eligibility because we are missing a significant amount of children and the impact of them being of small kids to what we're seeing in CPSC right now, it's significant. So again, this is another example of the city really taking the lead and providing the state with very credible data. Hopefully NICE will one day give us even more data. So I do appreciate that. You know, and everyone else who provides that information to your department.
So,
Oh, yeah. Yeah, I forgot to review the minutes from the last meeting, which was October 28th, and I just wanted to make sure everybody got them. And if everyone approves, we just need 2 people to say they're accepted. 1, 2. Thank you.
So, we're now gonna do the rest of the department report. Lydia Ledniak is gonna be talking about agency updates, post-April 1, AT, health homes. Jeanette Goff will give us an update on our academic collaborations, and Nora will talk about provider oversight and discussion we've had previously about a new committee.
Just wait for that PowerPoint to come up. Good morning. So, as Dr. Castellino said, I'll be reporting on the April 1st transitions, new agencies, and our technical assistance process. The implementation, the October 1st implementation of assistive technology, and so sort of where we are with our understanding and what the next steps are with health homes. Just grab that quicker, sorry. Okay. So this is the general message on the April 1st, 2013 provider landscape is that in New York City at least, is that the number of agencies continues to expand. I know that Dr. Castellino reported earlier from the state report that we have less agencies and more rendering providers, and rendering providers are consolidating under less agencies, but in New York City, we kind of have a different story to tell on that. So as you can see, April 1st, 2013, we had 85 providers, and as of March 30th, we have 105 providers. I think the largest increase we're seeing is around 88 providers. I keep reporting to you on this. April 1st, we had 31, now we have 58. SC providers, there's some growth, and new providers, there's some growth. I think and groups are pretty much remaining constant, but it's not the same mix of providers. So in New York City, you have some providers exiting, while you have other newer providers coming in to sort of take their place. And I think, and there's 40 new and existing providers that are right now in the technical assistance process. So there's a potential for at least 40 additional agencies. I mean, these agencies are in different stages of readiness, and some of these are existing providers who want to broaden what they offer in New York City, but most of that 40 is new people, new folks. So I guess sort of that's the story. It's a little bit different than the story, than the statewide perspective, and we've talked many times about with our other municipal colleagues about their New York City's experience is not their experience. It's different. And
Question about that.
sure.
So in the APA providers and the group providers,
Mhm.
are the group providers, are the group providers APA group providers or just developmental?
Both. That's
So
both.
there's no.
I didn't break that out.
Break it out. So
No.
we don't know if there are more,
I can break that out next time.
Right.
We know that.
okay.
And just an update, the provider directory, a mass update, because we have so many new providers already coming in, will be initiated by provider oversight in April. So we probably should have an updated provider directory on the website, hopefully sometime in early to midsummer.
Is there a sense that all the boroughs are being adequately covered by the new providers, or is there some preference service?
It's actually a very good mix, I would say. There isn't one borough that all the providers are flocking to. It might seem that way, but it's not. I mean, I think in certain boroughs where there was already a lot of providers, new providers are sort of may go there and then they're like, oh, maybe this is not the best sort of business move, so they'll call and we'll talk to them. Technical assistants will talk to them and say, maybe you'd have better luck going to a different borough, and they have been doing that. So we, the department, have been, we work with providers to sort of help them think through where they might go and where the needs are. We've been giving folks, these are the zip codes where we have difficulty, where we have need. When we work with them through the TA process, we look at that list to see, where can we go and sort of what are the capacity needs of the system.
When a new person comes on, do they, like I understand you help them determine where the needs are, that makes total sense. But are they, what's the word I want, are they restricted to a particular, when they finally become operational and decide where they want to be, are they restricted to that initial commitment?
The initial commitment that they make to the states. So usually they will go, the new providers go and they will check off all of the 5 boroughs.
Right.
But in terms of initiation, in terms of from a planning perspective, they'll say, well, I'm gonna start in a particular borough or a particular neighborhood and see how I fare. And then if they're not faring that well, they'll say, wait, maybe this wasn't the best idea.
So do they come back to, come back to the department and go, okay, I decided I wanted to be in Manhattan, but that's not working out, so they go back to the department. So the department kind of.
We act as a broker, kind of.
I don't want to say the word approve.
No, we don't approve,
It's not approval, but
we help them, we don't want people to fail, okay? Because if you come into our system and you take on 200 children, and then all of a sudden something happens, it's a problem for the families, but it's also a problem for the system. And how is the system gonna absorb if that is to happen? So we need to be, the reason that we develop this is because we need to be vigilant about, what our system looks like now, particularly post-transition.
So basically, the department kind of, I'm not gonna say improve, but gives the okay to a particular borough, and there's gotta be communication between the new provider and the department in terms of where they're setting up shop, so to speak,
Yes.
yes?
You know, email eita@health.nyc.gov if you're a new provider, or if you're an existing provider who wants to, I don't know, do groups, do more OT, I don't know, some new service that we all need. Alright, so health homes. So, as you all know, so health homes, the goal of health homes is to expand the availability of Medicaid care coordination services to more than 200,000 children across the state who are eligible under the optional state plan benefit created by the Affordable Care Act. The state sees health homes as being a natural linkage with EI. There have been, at the last LEICC meeting, I presented to you on what the eligibility criteria were for health homes. So it's 2 chronic conditions. And they are, and a determination of need. And how need is going to be determined is something that's still being discussed at the state. So I'm sort of gonna glaze over that unless you guys want any sort of additional detail on eligibility. Great. Current status. So the health home application period ended March 2nd, 2015. New York City Bureau of Early Intervention is part of the Health Home Review Committee at the Department of Health. So we've been looking at health home applications along with many other programs and offices in DOHMH. There are currently 34 agencies expressed interest to become a child-serving health home across the state. And so we're reviewing a portion of that. So like with other things in the state, health home approvals will be rolling. So between March 2nd and June 15th is when they expect to take on all of the health homes that are, sort of going to be operating. And then between June 15th and September 30th is when they're going to be conducting all of the system readiness, the training, the webinars, all of that for new health homes. So they expect to take children on in health homes in October 2015. EI impact though, even though they said that it might be more towards January 2016, they have not really announced a target enrollment date for kids in EI into health homes. New York City, along with other municipalities, are sitting on a NYSHO, New York State Association of County Health Officials, with a work group with SDOH and other municipalities to really talk about how health homes are going to be implemented in New York City. And so we just pretty much started talking about the specific operational details. We have not, I think from a state perspective, their priority is really, well, how are we gonna phase in all of the kids who are in various, Medicaid case management programs into health homes. I think they're still developing that mechanism. So early implementation phase in will come after they've sort of taken care of that. I think that the message around health homes is that, Medicaid redesign is very real and it's affecting all of us, and early intervention will ultimately be rolled into that in one way or another. So as a system, we have to be vigilant about sort of what the impacts are going to be on the families and the children that we serve. The other message is that we know that many early intervention providers have joined health home networks to become downstream health home providers, and we would encourage more early intervention providers to think about that, take that seriously, and consider doing that. So that when EI kids start getting rolled into health homes, that there is a built-in early intervention expertise there. Any questions? Health homes?
I just have a quick question. Our organization had a phone conference with Home Health just to get some more information because we were confused.
At the state?
Yeah, I believe it was the state, and I think part of the confusion they had when we talked about early intervention service coordination roles, and we looked at the evaluation tool that they use, which is not.
The CAMS?
Yeah, wasn't China, I know that all that's gonna be revised. And so what I'm hearing from you, Lydia, there's gonna be a liaison from EI working with them when we do the changes and the policy procedures that would be specific to EI. Because they were very confused with questions we asked regarding policies that currently, and they were like, we have no idea, we're gonna update all that. Because that would be my concern, them understanding what we do, our rules and regulations and the burden on, is it the service coordinator gonna be involved in doing that? Is it somebody else in addition to the service coordinator and all that?
So we share your concern on that, and that is really the work that this Nice State Show committee has started talking to, so who's on this committee with, early intervention municipal representatives is the lead health home team from the state, and also, Bureau of Early Intervention on the state side, so that we could all speak together about these issues. I think, one of the big issues that was brought up on the last conference call was what's the impact on Code 35 on all this? And so they don't know, they're thinking about it. So, and I think it's sort of like, we need to sort of answer the basics first, because if the state is going to keep their targeted case management approval for EI and also do health homes, which is also targeted case management, how does that overlap? How does that work itself out? So we're hoping that this municipal group is going to play a very active role.
I'm just curious to know, I know previously there weren't that many independent providers, and we're talking about agencies. Are you still working with independent providers?
Yes, we are.
And they're increasing as well?
Yes, they are. Not that many. I don't wanna say that there's 50. There's not. There's, 5, but
they're
it's starting to grow, and in terms of disciplines, we've just seen speech, special instruction, and now a couple of BCBAs. Nothing, no OT, no PT, nothing.
I hear everybody talking about health homes, I'm not really sure I still kind of understand it. Is there a difference between the new health homes and the old Medicaid managed care?
Medicaid.
Huh? Like the like SCIF, I think of them. SCIF
Is going to be a health home provider.
So it's similar to that?
It is similar to that, and the funding is different.
Okay.
And,
So it's a different funding stream, but it's similar, it's very similar
and
to
the
that.
eligibility is broadened,
And the eligibility.
right?
is broader.
So,
Okay, so that makes it.
two chronic conditions, let's just talk about it. So 2 chronic conditions, asthma, obesity, it's not what it is for these kind of, what we know today to be these Medicaid
Right,
case
like
management.
they're really sick.
Right, this is very different
This
than
is
that.
way
This
broader.
is much broader, and so, let's say you have a child with, general developmental delay, and the child has asthma, they technically met the 2 requirements. So that's not a, the threshold isn't that, but I mean, then the other questions that come up afterwards is, well, what is the level of need? How do you determine if this child is still appropriate for health homes? And that's, the devil's gonna be in the details on that.
And I remember years ago, doing this like maybe too long, when the EI was first beginning, the providers were encouraged to become Medicaid managed care providers, because most of those kids would turn into be early intervention kids, and so there were a number of agencies at that, not a number, but a couple of agencies at that time that actually went and did that. I don't necessarily know if they thought it was a successful thing to do at that time, and I know that dealing with the Medicaid managed care that are in existence now from an EI perspective, they didn't understand EI, and it was very, very, very problematic. So I think it's like deja vu all over again. I just get the sense it's, but on a much broader scale.
So, there are a lot of concerns, and I can tell you this, as I mentioned earlier, this came up at the SCICC. There are a lot of concerns, there are a lot of questions, as Lydia said, there's a lot of work going on at the state level, and fortunately the municipalities are being involved in the work. Our understanding of how this is going to happen in early intervention is the children families would get referred in for initial service coordination. At the point of assignment of the ongoing service coordination would be the point at which, and we have been told this will be a family decision, whether the child will stay with a traditional OSC within early intervention, or the family would decide to follow the path of the health home care coordination. So there are many steps in between that have to be worked out, and again, going back to our concern about families, we're working with families that will then have to make a decision at one point in time, but our concern is the ongoing service coordinators performing health home responsibilities, but being aware of the early intervention system and functioning in the role of an ongoing service coordinator. So there are a lot of details.
I think was not so much the EI coordinator had to become an expert in Medicaid, but even more difficult was the essentially Medicaid case manager understanding what the requirements of an EI service coordinator are. And that was even much more challenging. So.
And that's why we have encouraged the early intervention community to become involved.
And the rate would be, I guess the rate would be the rate, right? You don't know.
They're working on it.
Okay, more questions than answers.
Yeah, absolutely.
A lot of work.
Okay.
So, yeah, and we have two presentations.
Okay, so AT is implemented, there are issues, but we're working through them. We can talk about any of these concerns offline. Thanks.
Academic collaborations quickly, then I'm just going to do yeah, it is well.
It would.
Okay, yeah, so okay.
So while we're waiting for the PowerPoint to come on, I wanted to just introduce everyone to some of the faculty members that we have academic partnerships with. We have the chairperson, Dr. Shannon, and we have Professor Harula Natala from Brooklyn College. And then we have Jasmine Thomas. Jasmine, stand up so they can see you. From SUNY Downstate OT. So I just wanted to let everyone know that they're here today, just in case anyone is very interested in fieldwork placements for their students. You should come and approach them after the meeting today. Okay, so I'm going to briefly talk about just a status report on where we are in terms of the academic partnerships. Am I good with that? Okay, So, just to talk about what's happening with three of our main academic partners, with Brooklyn College right now, they are currently and will be meeting with partners to finalize fieldwork placements. We just actually met with the Infinite Child Learning Center at the Research Foundation at Downstate Medical Center. And they plan to also meet with TheraCare, Little Wonders, University Settlement, and Bellevue for other fieldwork placements for their students. And they are also completing their fieldwork handbook and manual, which will include the responsibilities of the graduate students, the responsibilities of the clinical supervisors, and any relevant forms or surveys they have to complete. They're also applying for continuing education credits for any EI professionals or postgraduate students across different disciplines who want to participate in this certificate program. And again, for Brooklyn College, they have a State Department of Education approved advanced certificate program in early intervention and parenting. So pre-service graduate students can take these courses, as well as postgraduate or EI professionals who are interested. They're also piloting the use of technology in the Human Development 1 and 2 courses, which Professor Natal is teaching. And what they're going to use is video equipment to record the interaction of the student with the family and the parents, and then use that as a tool for self-reflection and assessment of the student's use of family-centered best practices and embedded coaching. And they're also meeting and supporting our other academic partners as they come aboard with us. We had a meeting with Hunter College back in early February. We met with SUNY Downstate just a couple weeks ago at the ICLC Infinite Child Learning Center. And we're probably meeting with other partners really soon. In fact, last night I presented to the students at Brooklyn College that are taking Dr. Haru's class, Natal's class right now. And last week I met with graduate students at Teachers College, part of the Kiere program there, who are getting a dual degree in early childhood and early childhood special education. So we're doing a lot of outreach in the community. And they're also finalizing their evaluation plan for the advanced certificate program, which will include surveys completed by the students themselves and by the clinical supervisors. And they're looking at what kind of data to collect and what kind of tools to use. And some of the tools we're thinking about using are the National Environments Rating Scale and Russian Sheldon's Coaching Practices Rating Scale. So that's what we're doing so far, because it's a lot that we have to do. SUNY Downstate Occupational Therapy Program, they decided to create a core EI curriculum for those graduate students in the occupational therapy program who want to work in early intervention after they graduate. So it will consist of 3 courses, Intro to Early Intervention, Topics in Early Intervention, and an elective in Early Intervention. 2 of those courses are going to be online. So right now they're creating and finalizing the curriculum for those 2 online courses. And they're also working on completing their fieldwork handbook as well, which also will outline the responsibilities of the graduate students, include the parent consents for those students to work with those families, and also they have a self-assessment tool that they're going to give each student to complete prior to the start of the EI core curriculum, after they finish their coursework, before they do their field work, after they do their field work, and 6 months after they graduate from the program, to get some feedback on how well the core curriculum prepared them to work in early intervention. So it's like a self-assessment for competency in early intervention. And Brooklyn College is going to do the same thing. I think they're going to do their post-assessment 1 year after, to see how many people end up working in early intervention and how well the certificate program prepared them for early intervention as well. So we've been meeting also with Hunter College to prepare academic partnership with them as well, and they're finalizing the proposal for us to review. They're thinking about providing early intervention courses within their school of continuing education. In this way, graduate students or EI professionals or postgraduate students from different disciplines may register for these elective EI courses. We're going to maybe at the next meeting, LICC meeting, be able to report more in detail about their academic partnership. And also, we recently met, Dr. Castellino, Lydia Letniak, and I met recently with Dr. Wolf and Dr. Wang at Queens College, and Dr. Rodriguez, Dr. Bacon, and Dr. Gottlieb at Lehman College, to see also if they would be interested in participating in some form of academic partnership with the Bureau. So, are there any questions? It's a lot of work going on. I keep doing this. Right? Is it the middle button?
No, it's a side button.
The side button.
So, because we're firming up on all the fieldwork placements, if anyone's interested in working with students from Brooklyn College, they can contact Amanda Lopez or Dr. Shannon. If anyone's interested in working, doing field work with the OT students from SUNY Downstate, please speak to Jasmine Thomas, who's here today, but that's her email as well, and Dr. Beth Alenko. And the last thing I want to mention is that we have upcoming professional development trainings that will happen probably later this year, but we haven't finalized their dates. One is on reflective supervision training with Rebecca Shamoon-Chinook, Gail Gordon, Phyllis Ackman, and Elaine Gella. And the second training that we're going to offer for the Bureau is on bilingual evaluations with Catherine Crowley. Okay, that's it. Thank you very much.
Nora, just do the provider update, because we're running really short on time. Okay. We do have an agenda item. Nora was going to talk about the new committee. Do you want to, shall we postpone yours? Let's postpone Nora's till the next time, because we have some guests. Yeah, that's fine. Okay. So go on to
Health insurance.
Robert Stevens?
Yes. Hello, how's everyone?
Hello.
Sir, panel.
Thank you. Okay.
Very quickly, I'm not going to take up a whole lot of your time. My name is Robert Stevens, Liaison Manager for the Office of Health Insurance Services, actually the new Preventive Primary Care Division under Dr. Bassett. The Office of Health Insurance Services has enjoyed a relationship with the Early Intervention Program for quite a while now, for a few years. And basically what we've been doing is we've met with a number of the providers, actually, hopefully all of them, and hopefully with the new providers we'll be meeting with you as well. And what we've been doing, we've been training service coordinators on referring clients or their family members who may require health insurance. And it's been wonderful. We thank you for the efforts that you've made. We've conducted in the past 3 to 4 years, we've conducted close to 200 trainings, meeting with close to 1,700 service coordinators. Of course, some of the older service coordinators and the new service coordinators. And we received close to 4,000 referrals from you. So we thank you, and we've been able to assist some 800 families with health insurance services. Not only do we do the health insurance services, but we also assist with food stamps to SSI and so forth. But health insurance has been primary. With the advent of the Affordable Care Act, the state has trained our facilitated enrollers, and they are now certified application counselors. So we've been able to do even greater things. We've been able to now assist anyone between the age of birth to 64 years old. And you know, health insurance is extremely, extremely important for the early intervention population and the general public. And so if you know of anyone, if you have any concerns with your families or of neighbors or anyone that you may know, please refer them to us. This particular packet that we've given to you, you can make contact with us. We're actually right now making inroads, hopefully, with DC 75 to gain contact with family members and parents and so forth who may require health insurance services. And what we need to understand is that health insurance is for everyone. All of us are affected by it. So again, with the advent of the Affordable Care Act, we're able to do even greater things. We concentrate again on the early intervention program and their families and the EI child, the sibling, and family members as well. Again, we're able to assist anyone between the age of birth to 64 years old. So again, to the EIP program, we thank you for this collaboration, for the relationship, and to the providers, thank you. You're doing a marvelous job. Thank you.
Hi, good morning, everyone. I'm Renee Noel from the Bureau of Child Care, Department of Health and Mental Hygiene. And I'm here to discuss with you the flu mandate that was recently enacted. And I wanted to let you know that it's a collaborative effort between two bureaus within the Department of Health, the Bureau of Child Care and the Bureau of Immunization. And I have a colleague here with me, Paula Francis Crick. And she will jump in when, if any of you have questions. Okay, so the flu mandate, right? All children ages 6 months to 59 months, just before turning 5, enrolled in childcare must receive the influenza vaccine before, by December 31st of each year, okay? Okay, so who's affected by this mandate? And the programs that are affected by it are the group child care centers that are regulated under Article 47 of the New York City Health Code. Also, the school-based child care regulated under Article 43. So Article 43 programs are children that are 3 to 5 years old within a school or elementary institution, educational institution. So like a yeshiva or the archdiocese, these little private schools. So just that 3 to 5 year old is regulated under Article 43. So those are the programs that will be affected by this flu mandate. Okay? So the state programs are not covered under this mandate. And we have programs that we call legally exempt. They are in the home. The home programs are not under this mandate. The legally exempt are programs that have less than 2 kids, or they're not regulated at all. And so the reason behind the mandate, the highest priority is the daycare centers because of the environment that these children are in. Close proximity, personal hygiene is not at the utmost. It's hard to get a 2-year-old to, cough into their arm. So that's the influenza can spread easily in that sort of environment. Okay? Oh, sorry. And also, statistics were, research and all of that done in regards to, out-of-pocket expenses, having to go to the emergency room, the expenses that posed, as well as parents having to stay home and lost wages. Okay, so all of that was put into, brought up. And just giving you a visual of how it can, a child becomes the source of infection in the entire community. to the family, to their peers, and to the larger community. And so vaccinating the child is promoting herd immunity. So you're helping the other individuals in your classroom as well once you're vaccinated. Okay. And sorry. Okay, so this diagram is just it's giving you the numbers prior to the influenza mandate, the flu mandate, and we have some numbers for now, like recently since the mandate. So the mandate went into effect January of 2014, and so these are the coverage of the age group that had at least one dose during the season. Okay, so as of March 11th of this year, we received data that is at 63%, and it's climbing, obviously. And so the hope is that it would go up to 90, even 100%, but as high as possible. That's the goal. All right, so all this statistical information was taken to the Board of Health. It has to be approved by the Board of Health prior to being enacted. And so we had public comments, we had, and individuals spoke up at these public comments, and we took all that information and the board made a decision. And their decision was made on January 11th of 2014. It was enacted. So programs must be in compliance by December 31st of 2015. So the reasoning behind that, we wanted to do education as an enforcement instead of initially coming out and doing citing violations. So giving people, programs, daycare centers, opportunities to speak with their parents, get all the information that they need, provide it to their parents, so that by December of this year, 2015, they would all be, understand and be able to be in compliance with the mandate. So right now we're just doing enforcement. The flu mandate, we had blast emails sent out to the programs, letting them know about the public comment, notices about the providers after we sent out notices to the providers after the Board of Health approval. We sent out flu mandate posters, letters that they can give to their parents. We wanted to educate them and give them as much information as possible. We also did presentations at specific organizations. So the first year, education. We're just promoting, sending out materials, letting them know. We have a media campaign. If you've noticed in the subways, there's the flu posters in the subway stations. And so that was our hope, to make sure. So no violations are being cited. We're not issuing notices of violations to any of the programs. We're noting it in our reports. We're educating them. We're giving them the information. And year two, which is December 31st, 2015, so that means January of 2016 is when we begin issuing the notices of violation. Okay, so programs will have to be in compliance by then. Okay. So the exemptions, this is the main thing. A lot of phone calls have been coming in. They want to know what to do. Parents are against it. A lot of parents, they don't want their children vaccinated with the influenza. So there are only two exemptions for medical contraindication and religious grounds. Okay, so for medical, you have to get a doctor's note. It has to be signed by the doctor. It cannot be the doctor, which we've seen, the doctor says that the parent refuses to give the child a vaccine. That is not acceptable. It has to be, it's a detriment to the child. The child is allergic to it. It would be counterintuitive. It won't do anything for the child. So that is the only reason. It has to be from a doctor and signed by the doctor. The program can ask for additional information. They can call the doctor. It's their prerogative. They can do that. Religious grounds, this is the parent giving the letter to the program. just with their sincere and genuine religious belief. It cannot be philosophical or anything like that. It's just their religious belief that it's against their religion to vaccinate. And again, the program, the director, the owner can ask for additional information. If they wish, they can ask from the clergy member or rabbi, whoever that they request. But as regulatory, we go in, as long as we see in the child's record that the medical letter from the doctor or the religious letter from the parent, we accept that. If we're not going to go dig further, it's up to the program to do that. Okay, so the program's obligations. Retain completed medical forms for all children enrolled, have medical forms readily available for our inspection. Ensure all children enrolled have the required immunizations or the exemptions. Adhere to the health code in which they are governed under, which is either 43 or 47. And the permittee may refuse. So the program may refuse to allow any child to attend a child care service if they do not have the vaccine or the exemptions. When we go in, we're not going to say, okay, the child doesn't have anything. We are not going to say, oh, send that child home. We're going to issue the violation to the program, and it's up to the program to make that corrective action, whatever that corrective action is. And they can exclude the child, but we won't exclude the child or tell you this child must go home. Okay. These are the posters. I don't know, I'm not up there, so I can't pull it up, but the posters are online and readily available and in different languages. Programs can call, parents can call and to our 311 call center, and it can be mailed out to them. And also the influenza health bulletin is available as well on our website. Monitoring all the I can't even say the word anymore. Statistical information that we've received is from our citywide immunization registry, which doctors, most pediatricians have this on, they put all the information in there, and we are able to monitor what's coming in and who's being covered and who's getting the immunizations. And what we're doing with programs, daycare centers, is asking them to register with the citywide immunization registry, which helps them in a sense because they can go in as well. They get their password and everything. They can go in and they can see if the child is up to date with their immunization. And so this is what it looks like. The citywide, it's on our website, Citywide Immunization Registry. And this is our contact information, the Bureau of Child Care, our website, and borough office contact. We're decentralized, so we have all in 4 boroughs, not all 5. Brooklyn and Staten Island are together in Brooklyn, and we have Queens, Bronx, and Manhattan. And so all the contact information is on our website at that link. And the phone number, our main number at central office in Manhattan is that number I just gave you, that's up there. And for immunization, the Bureau of Immunization, that's their link to the website and their contact information, their phone number. Okay, and that's it.
I just have one question in terms of the exclusion, the sending, I'm sure other people. So if a program is going to be cited with a violation, if the child doesn't have the immunization, is there any other documentation that they can have to show? Because I think the program's in a really difficult position. Because if you're not going to order them to send the child home, and I as a program send the child home, the parent's going to be really angry at me if I'm not ordered to do it. So I think that has to really be looked at. Mm-hmm. And then secondarily, if a program has notes from a parent that they have a doctor's appointment in February or late February or whatever, is that sufficient to cover it? Because I think those are issues that programs are going to face, because this year there was no enforcement, so programs didn't exclude kids. What I've heard from program providers already is that they're planning to exclude kids as of January 1st, and the onus is going to be on them if the department isn't telling them to exclude kids.
Right. Okay, so we'll look into that, but we just we can't really, we don't have that the relationship with the parent. You
Mhm.
understand? It's the provider and the parent that has that relationship. We just oversee the daycare centers and the programs, so that's where the obligation is. So we cite the violation, we can't, I don't know why it's written in the code that it's the provider's, decision.
Yeah.
I believe it's because it's their business, their organization, we're just the regulatory, where it's, I'll take it back, but I'm not sure why, I know they want something to fall back on, they want to say, well, the health department, told me, this is the, and I've been getting the calls and I understand, I've spoken with parents, I explained that to them as well. But, I don't know, I'll have to put that one.
I was gonna just say the same thing, because it's the word may,
Yeah.
that leaves it so open, and like Chris is saying, the parent can come and say, but I have an appointment next week, and I know that happened this past year, like you're saying, it wasn't enforced, so people kind of gave the parents the wiggle room. But I think what you're saying is, if the daycare comes and you don't have documentation to the exclusions that you mentioned, but there's a child here who doesn't have an immunization, then the daycare is gonna get a violation.
Yes.
So it's kind of like, kind of like a contradiction from the department, then, like you're saying, if you're putting the daycare or the school in a very difficult place.
Okay, all right.
I have a quick comment. In regards to, and we're not the regulatory body that oversees the child care, that's Renee's department. But from the Bureau of Immunization's perspective, if a child has an appointment, a documented appointment, in the record indicating that they have an appointment to get a vaccine, then it's a show of good faith, and most facility directors will accept that. And it would be considered more like a provisional, the child is in provisional status, or they're showing good faith that they will get the vaccine. It is then up to the daycare director to follow through if the child did in fact bring in documentation past that appointment date if they got the vaccine.
So you can't speak for the daycare people, but you're assuming that if they were to come and visit, but they had that documentation, then they wouldn't be issued a violation? And then whatever that date is, they would show the documentation and send it to the...
Yes, it's what we also tell schools, the private schools, public schools. Once a parent is showing good faith, then there's no reason to exclude the child. Then up to the person, the director of the facility, to follow through and ensure that the child kept the appointment, brought in documentation. If the due date has passed and there's no documentation, then it's up to the director to take further action, and they may exclude the child.
Fair enough. Thank you.
I feel the need to say as a medical provider that the flu vaccine, unlike all the other vaccines, flu season, you really have to have it by December or you're not going to be protected for the season. So this is one of those things that's not only a bureaucratic date, it's an actual health indicated date.
Any other questions? Thanks very much, thank you. Okay, so I'm gonna make my report really quick. I had just wanted to give an update. The Early Intervention Provider Associations got together, I think it was in December, I don't know, it was snowing up in Albany, that's all I remember. And we came up with a recommendation to ask the legislature for a 4.8% increase for EI rates. My understanding is that was turned down. And one of the things though that came out from this is that there was some questions regarding the lower utilization of early intervention services in the state of New York. The governor's budget lowered the amount of allocation for early intervention by $4 million. And part of justification for that was that there were fewer kids using early intervention. Also, there was an abundance of providers. There were way more providers providing the service, and so they didn't feel that there was a need for any kind of early intervention increase. So one of the things that the advocates did ask for was in the legislation in the budget bill that both the Assembly and the Senate put out, we asked for language regarding data collection and some much more intensive numbers on behalf of the state and the municipalities, so that we would then be able to make some arguments regarding the need for these increases and other things, and also verify whether or not the numbers have actually changed that significantly to warrant changes in the amount of money in the allocations. And I don't know at this point whether or not that language actually ended up in the final budget bill, because who knows, that's one small piece of it, but hopefully we'll have an answer at some point regarding that. The other thing I just wanted to give you an update on was regarding the school psychology issue. And it has impact in two ways. One, it certainly has an impact on the children leaving early intervention, whether or not they can be evaluated or not. And the school psychology issue started regarding state education departments' enforcement of regulations that school psychologists are no longer seen as eligible to be able to do evaluations on children who are not enrolled in 4410 programs. And then the state issued another revised memo saying basically they weren't going to enforce it. The reality, though, is that there are many 4410 providers that are evaluation sites that are not doing evaluations unless they have a licensed psychologist doing it, which is someone with a PhD. It's also very complicated. There's very few licensed bilingual psychologists to do any kind of bilingual evaluations. I participated in a meeting a few weeks ago with members of the state Senate, members of the Assembly, people from State Ed, Office of the Professions, and all of their legal counsel regarding this issue. A number of provider groups were there. And one of the things that came up was a debate about whether or not they were going to proceed with one of two tracks. One was going to be a waiver that would grant a waiver for school psychologists to conduct 4410 evaluations initially for kids. And then the other was whether or not they would create a new licensure for school psychologists. The Office of the Professions and people in State Ed and others said that would be a very difficult thing to accomplish. So it looks like they're moving towards a waiver for initial evaluations, allowing school psychologists to conduct those. However, the language is problematic, and just so you're aware, what the language in the proposed bill says, and it's an Assembly Bill 5325, it was introduced by Assemblymember Glick, and the challenge in the language is it basically says that the person conducting these evaluations has to be employed in a salaried position by the center-based provider, and a certified school psychologist has to then be in a salaried position. Well, we've already sort of gotten an indication that most school psychologists right now are not salaried, and they are hired as a consultant on an hourly basis to do the evaluations. So most of them would not be eligible for the waiver under this. So we've already started to reach out to some of the members of the Assembly to start to see if the language can be adjusted, because we don't know exactly why they said salaried position, and we're trying to look into that. So hopefully we'll have some more updates on this.
And I thought that part of the bill was going to be in the governor's budget that's going to be due tomorrow. That's what Pam had originally said. That
This is
portion
a
was going to
separate-
be in the budget, and the possibility of licensing school psychologists would be in the legislative session.
I'm not sure. What I know is that it's a separate bill now. I don't know if it made it into the final
We'll
language.
find out.
Exactly.
We'll find out tomorrow. Okay.
Okay. All right. Thank you. And then I think it's just the committee reports. Kathy,
I have nothing.
Tracy, who's the new chair of our policy review committee.
Yeah, just very quickly, we reviewed revisions to the transportation policy. I think the EI community would be happy to see that parent reimbursement and car service options are again going to be available for families that need them. Our review led to one major modification, mainly that the distribution of Metro cards and gift cards, which are part of the policy, is actually gonna be assumed totally by the department, so service coordinators and providers won't be involved in that. And so Chris sent the policy out to the full LEICC for review last week, and comments were due yesterday. So hopefully we'll be seeing that policy coming out soon. I think our next task is gonna be tackling transition, and I'm told we will actually be working our way through most of the policy.
And then Mary,
Jeanette has already
That's right.
talked about Hungary, and we're going to be meeting this quarter on how to have a family-centered emphasis throughout all the.
is there any public comment? No. Right on time. Okay, thank you.